now, if that's okay. So hi, everybody. Welcome to our CDCR seminar. I'm really excited today. We have a new experiment. We're going to have a dual speaker joint virtual and in-person setup today, which should be exciting. And thank you, Paul, for helping me to navigate this. So I just have a quick announcement first. So a reminder that Research Day is coming up. It's September 26th. You guys all know how excited I am about our keynote this year. It's Dr. Crystal Makel coming from Stanford University. We're near our max for registration already. So please sign up because Paul's going to be very strict about numbers. So if you don't register and you show up at the day, I'm not sure we can let you in. Right, Paul? So please register. And if you can't remember, just email cdcr@mcmaster.ca and indicate your desire to register. So with that, I would love to introduce our speakers today. So I am really happy that we are going to hear today from our very own and beloved Dr. Tobias Berg, as well as Dr. Aly-Khan Lalani. And Dr. Lalani is doing absolutely amazing research. We'll be very fortunate to collaborate with him. He's an associate professor with McMaster's Department of Oncology and is a medical oncologist at the Juravinski Hospital and Cancer Center and is chair of the Juravinski Genitourinary Cancers Disease Site Team. He's an associate member of the CDCR and his interests are in cancer drug development and therapeutics. He's spearheaded many exciting clinical trials while co-hosting a GU-focused podcast as well for students who are interested. Dr. Berg, of course, needs no introduction, but I'm going to introduce him anyways. He's an associate professor with McMaster's Department of Oncology, a clinical hematologist at the Hamilton Health Sciences Juravinski Hospital and Cancer Center. Of course, we know he specializes from many perspectives, scientific and clinical, in acute myeloid leukemia and allogeneic stem cell transplant. I want you guys to know that bone marrow transplant physicians are known to be the most technically skilled of all physicians, except neurosurgeons. But they are highly, highly technically skilled and very coveted people that when you're able to recruit one, it's like the entire hospital cheers because it's so difficult to find these talented individuals. So we're so lucky because Dr. Berg not only contributes this huge clinical skill, but scientific skills to the CDCR. And you know he's the director of our translational oncology program. And so Dr. Berg and Dr. Lalani, along with Dr. Daryl Leong, who sadly couldn't join us today, they're leading a new Juravinski Research Institute initiative called Elevate PM, Enhancing Liquid Biopsy Evaluation and Data Analytics for Personalized Medicine. And the project which we're going to hear about today is going to revolutionize cancer care by using liquid biopsies and AI-driven data analytics to detect minimal residual disease, which is of great interest to my glioblastoma team as well, and personalized treatment plans. So the collaboration is this really beautiful interdisciplinary work. And ultimately, I think they're going to improve outcomes for patients with bladder cancer, kidney cancer, and AML at the Juravinski Hospital. So help me to welcome Dr. Aly-Khan Lalani.
Thanks very much, Dr. Singh, and really the whole team. I'm hoping you can hear me well, and I'll just plug along. I think this has been a great introduction, and again, I'd love to be in person with everyone together sometime. So as mentioned, this is myself presenting, and I know Dr. Berg will be up as well, and we have a huge team which I'll try and introduce you to along the way for the citywide approach called Elevate PM. So probably this group knows well, but just to level set at a very high level, personalized medicine gets used a lot. Sometimes it's a venture capitalist term and private equity term, and sometimes it's really what patients want. But ultimately, I think we all agree it involves customizing treatment strategies based on tumor biology and individual patient characteristics to make it really a personalized, bespoke approach. Cancer biomarkers, as this group knows well, are essential tools, and obviously they can be prognostic for clinical course or predictive for response to treatments. And the toolkit for solid tumors especially is rapidly expanding. These innovative blood tests, and we've called them liquid biopsies, which in the solid tumor space you'll hear about today is as simple as a blood test. In some other blood cancers that you hear about could be a bone marrow biopsy, but this is felt to be a non-invasive way to detect minimal residual disease. What is that? This is, at a very simplistic level, a small number of cancer cells that remain post-treatment, very easy to define, very nuanced to capture well, and we'll talk about that. Why does this matter? Well, in patients who get particularly curative intent treatments, meaning treatments that are designed to cure a patient's cancer, having the ability to check for MRD can signal a higher relapse risk and very much guide additional therapy. So this is, in some ways, it can be biomarker discovery, but in large part, the aim here is to really influence cancer care at an individual and ideally at a population level. So what's the clinical issue? And I think hopefully what we'll do here is to highlight the important need that we see in the bedside and how we're trying to go to the bench, so to speak, to help and come back to the bedside. So solid tumors, which I'll talk about from a GU perspective, but this really involves cutting out a cancer that is felt to be localized, so what we call non-metastatic. And so a case example could be kidney cancer, in which case our uro-oncologists, largely at St. Joseph's Hospital, but also at the JHCC, would do a partial robotic or a radical nephrectomy, essentially taking out visible cancer. In bladder cancer, this is quite an intense procedure. Patients have their bladder removed. When you take out a bladder, how do you pee? You need an ileal conduit, so you divert urine to a bag on the body, or you can cut out the bladder and reconfigure a small intestine to store urine, which is called the neobladder. This is not a small surgery. A lot of synoptic reporting on these type of cassettes that are sent to our pathologists to report on, and this is currently providing a large amount of information as to how high risk the patient's bladder cancer is. So we oftentimes administer systemic treatment. This can be chemotherapy, what we call cytotoxic chemotherapy, or immunotherapy after surgeries. I've just given you two examples that can help reduce the chance of the cancer returning back to a patient who's been told by their surgeon they are cured and all the cancer is gone. And that delaying that cancer coming back is called a disease-free survival benefit. And if that can improve a patient's lifespan, which is a harder bar to hit for early stage disease, there can be an OS benefit. So sounds cool. All treatments, especially systemic treatments, carry inherent side effects. And some may be long lasting, especially immune therapy after treatment. So it sounds great, but we do see patients that have significant side effects when they're told they are in a cured setting. I think the big, bold point here that we felt as we were first approached by the Juravinski Secretariat or the JRI Secretariat to come up with an idea was that we often don't know how to predict which patients we are seeing in our clinic are at highest risk for cancer recurrence beyond the tissue that I just told you is cut out by surgeons, which is excellent. So we oftentimes talk to patients that it's insurance policy treatment to delay cancer recurrence. And it's not to be too cheeky, but oftentimes it's a hope and prayer and good surveillance. So we felt, like others feel, we can do better. So giving adjuvant therapy, so imagine a patient is sitting there cured of their cancer, so to speak. What happens? Well, there's a whole bunch of patients. What you'll see from this diagram is that there are patients in the bottom left, in the light green, who no matter what we do to them as medical oncologists would have been cured with the surgery alone. They were destined to never recur. These are patients cured by the knife. Then there are patients, unfortunately, when we do see them and they're told they are cured, that no matter what we do, systemic therapy-wise, unfortunately, they are resistant to that disease, and that's very devastating. There's that middle window where patients have their cancer cut out, have microscopic disease that is sensitive to systemic treatment. And that's that window we're really trying to get. So if this box represents all the patients waiting in my clinic for treatment, for adjuvant therapy, you can see I'm inherently over-treating some. I may be under-treating some as well. And not all patients choose to go for adjuvant therapy. So we need to find that perfect middle zone. I'm just going to give you an answer, and I'm not trying to have too many clinically heavy slides, but I think it's relevant for you to hear why we're bothering doing this. So let me give you a case example from a GU cancer perspective, and this will hopefully set up what we're doing and why we're doing. So case example 1, kidney cancer or renal cell carcinoma. So we have a trial that we did at the Juravinski and essentially has been approved around the world. You can see on the left, there's a bunch of language there about T stage, this is tumor stage, and There's certain T stages of these kidney cancers that were included in this trial, and patients were randomized to get IV placebo or IV immune therapy for 1 year and to see if we could delay the cancer coming back. So tissue is what was used to guide the risk of recurrence. Okay, so what did we find? Being higher up on the curve is better. That's a better outcome. So the pembrolizumab arm, you can see, did better. It delayed the chance of coming back significantly. If you tell a patient at 5 years, the chance of being cancer-free is about 52% with the surgery alone, we can make that 60% with doing 1 year of immunotherapy. And for many patients, 5, 8, 10% of improvement in DFS is something they would absolutely do. So this is an approved, globally approved standard of care. There's a cost to doing business, right? So not to belabor this at all, but just to highlight in red. Side effects that these cured patients could be admitted to hospital for because of our treatment could happen in 1 in 5 patients, and I treat a lot of these per week. Immune-related side effects, which are ones that need steroids to calm it down or could last forever or a long time, are 1 in 10. And that's not inconsequential. So there's a cost of doing business, not financially. I'm talking here to the patient's health. So how could we do better? This is where it comes down to our project. So we know that kidney injury molecule 1, or KIM1, is overexpressed in RCC and is shed into circulation. So kidney injury molecule 1 is overexpressed in different types of kidney cancer. So that's the key. Is it not just the vanilla ice cream that is clear cell, but other more rare or divergent histologies like papillary RCC, but it's not expressed in healthy kidneys, and that's really important. This is a 90 kilodalton ectodomain that is detectable in both urine and plasma. There's been data and presentations, as you see on the left, 20 years ago that showed it could be seen in lymph node metastasis, the clear cell kidney cancer itself, but not in normal tissue. On the right, there was some data showing that among their sample of 190 RCC patients, KIM1, and this is what's really cool, was elevated in banked plasma up to 5 years prior to diagnosis. Let's keep that in mind, because wouldn't it be amazing if we could screen patients for a cancer with this test as well, prior to them even having it? So there's lots of clinical data. So we aren't taking one trial and just trying to make a biomarker discover here. I think we have enough, and we're on the wave of more data coming. On the left, showing that the KIM1 structure, this cleavable ectodomain, can be captured in patients prior to their surgery, after their surgery, which is the scenario I told you about, getting insurance policy treatment, or even for spread disease. Now, spread disease, these patients are on systemic treatment. They have stage 4 cancers. They're getting imaging, and there's some potential utility there. But you can imagine getting a better sense of those who are told they are cured, and if there's minimal residual disease in their blood, it's highly valuable. What do we know already? I showed you an approved agent, and isn't it interesting that even on clinical trials that are performed but are not found to be the standard of care, they have usually a plethora of biomarker work, and we can learn from them. These trials were all negative for their drug to help kidney cancer patients that got it cut out. However, all the biomarker work on the left is a trial of pills, TKIs. In the middle is an immunotherapy trial, and on the right is another immunotherapy trial. All these trials showed that if you look at quartiles or even the KIM1 high level, all the KIM1 high patients did worse in these trials, and it was therefore prognostic. So we know that even from negative clinical trials. What's really interesting is some of these negative clinical trials showed that actually KIM1 may predict benefit from adjuvant immunotherapy. And if you don't look at a lot of Kaplan-Meier curves, I'll do a very brief explanation that on the left, these are all patients in a trial, whether they got placebo or immunotherapy, that had high KIM1. And you can see that atezolizumab helped those patients perform better in terms of a clinical course. On the right, the KIM1 low group, whether they got either treatment, they did well kind of no matter what. So I showed you before it's prognostic, but now you can see it's predictive because the KIM1 low did well no matter what you did. So those are the patients you're probably over-treating in your clinic. The KIM1 high patients is the ones you really do want to treat. So the next wave of questions obviously becomes, for all these patients coming and seeing me and my colleagues, they've got a cutout kidney cancer. Instead of giving them all immunotherapy, why don't I randomize them to doing treatment or not, based on this KIM1 blood test? And wouldn't you know, the first step is Can we do this KIM-1 blood test in routine standard of care? So that's the clinical context about why that matters. Bladder cancer, I'll go quicker here, but tell you the same story. Patients who have that big bladder surgery I was telling you about, and it's cut out. On the left, you can see that these patients on the higher curve with immunotherapy seem to benefit. On the bottom right, it's the survival curves. And you can see that these patients benefit, and therefore this is a reimbursed standard of care based on the tissue sample that was cut out. And we use that to say, hey, are you high risk or not? So how could we do better here? So ctDNA, and this group might have heard a lot about this, but just at a very brief level, all of us, but especially those who have cancer, a fraction of cell-free DNA in our blood is tumor-derived. That's called ctDNA. This is slightly smaller than cell-free DNA. And ctDNA is identified by features absent in the blood cfDNA. So DNA mutations, there's structural rearrangement, there's methylation marks, which I think is very interesting. You can do fragmentomics, but the ctDNA percentage is relative to the volume of active and proliferative cancer in the patient's blood. And you can imagine having a high level in your blood, knowing that after surgery could help dictate whether you should get treatment or not. It's important not to say, okay, let's just do ctDNA now, it's good to go, because one size does not fit all. Are you trying to detect cancer, in which case you better be tumor informed, because doing naive or tumor naive testing may not capture what you want. Do you want to quantify? Doing deep targeted sequencing, this is where targeted methylation sequencing can help. And do you want to characterize what's in there? So the second one from above, detecting minimal residual disease, is really what we're trying to do, but there's a lot we can build upon if we can make this routine and not outsource this and do this locally in McMaster, because now we can learn a lot. So the test choice must match the clinical question, and we're trying to detect minimal residual disease. So how do you detect minimal residual disease where there's tumor informed, which I think is the gold standard? That's using information about the individual cancer. So we take the bladder cancer tissue, use that to inform an MRD test. This is very specific, but it can be costly. If you say, well, it doesn't matter, let's just look at any tumor ctDNA in the blood, well, that isn't tumor naive. It's quick, but it's lower specificity. And you can imagine in an advanced kidney cancer patient, lots of stuff in the blood, maybe it doesn't matter and you could do that. But in a so-called cured patient, you really need to be really, really sure if you're calling ctDNA present or not. I think there's lots of ways we can do better to be tumor informed. And I think that's where our opportunity lies. We can have, detect more mutations and look at some fragment features and even being able to have greater input of cfDNA. But that's one opportunity we have. Now, the risk with doing ctDNA is CHIP or clonal hematopoiesis, which is a confounder, right? We have a lot of elderly patients as a whole that can have clonal hematopoiesis present. Bladder cancer patients, median age of diagnosis is like in their 70s and 80s. So, you can imagine you put those two together, and that's very hard to resolve if we don't do matched white blood cell sequencing. So it's going to be really important as we start to launch this to think about this logically and carefully. And so why am I making this case? Because just like I showed you in kidney cancer, there's a next wave of questions in bladder cancer to say, okay, on the left, this is medical jargon. If it's not familiar to you, it's just these are patients who have had a surgery and are deemed high risk. They would be randomized. In this study, if you're ctDNA negative, isn't that cool? You're still high risk, but you're ctDNA, we would just surveil you if we did this trial. If you're ctDNA positive, you could be randomized to getting immunotherapy or placebo. So this trial would be trying to answer, is ctDNA testing better to select patients for adjuvant immunotherapy rather than giving it to everyone on the left side of the slide? And can we save patients from that unnecessary toxicity? So knowing these trials were coming is why we spent, I would say, from last summer and winter to develop our LOI and incorporate bladder cancer patients. And wouldn't you know, just August 18th, this trial I showed you has a positive press release. So clearly this is coming. First time ever for bladder cancer that ctDNA is found to be helpful. So this is real, it's here, and you can see that this is Natera and the Signatera test. So it's proprietary. We can work to externally validate what we're doing, but we want to make sure we are ready to do this ourselves. And that's important because if we can do this in my clinic, and we have a muscle invasive bladder clinic at the Juravinsky, we can take ctDNA at baseline. These patients get chemo prior to their surgery. We can take blood tests potentially right before they get their surgery and to see what's going on, and we'll get a repeat CT scan. And then wouldn't it be amazing to say, hey, if you're undetectable after radical cystectomy, you are good. Maybe we don't need to do anything, save these patients a lot of treatment. But if you're still high risk or have positive ctDNA, those are the ones to treat. We need to be able to do this test locally. So this was a bit of background for GU, and I'm going to turn it into our project. So you can see why I hope you've got a sense that our overall objective is to enhance personalized medicine for patients by leveraging these innovative blood tests for MRD detection. We're going to start with demonstration models, and that's why I've given you the preamble on kidney and bladder cancer. We're also going to hear from Dr. Berg about hematological cancers. Specifically, this is important. We want to make it a platform and not just a one-off experience. Can we, and we seek to, establish a coordinated, systematic liquid biopsy testing and analysis process from point of care here at the Cancer Center, start with these demonstration models, and this is where EPIC comes in. We can create an automated, streamlined process for screening, identifying these patients. I've tried to show you they get their surgeries in different hospitals across the city. We need a citywide approach, and we can highlight and follow these patients moving forward. So, using information from electronic health records, along with data analytics and AI, we can build a streamlined system to collect, analyze, and then obviously test for specific blood biomarkers. So I've tried to make the case in RCC, KIM1 is cheap and available and totally possible to do. ctDNA needs to be tumor informed. It is more costly, but we can do that locally. And you'll hear more about MRD testing from Dr. Berg. These are two demonstration models. I could make this case for other cancers, but these are the ones that we treat and ones that are most on the horizon. The key aspect here, and this is where our collaboration across the city with groups like yours and others is really important. We want this to serve as a foundation. Our aim is to scale up. We've been recently profiled in the press, and I've already gotten my colleagues saying, hey, my breast cancer patient wants to do this. Are you ready? We've just gotten an award. We're hiring coordinators and ready to go. But you can see that we want to roll this out for every cancer. And you've heard from Dr. Singh about even CNS types cancers would be of interest as well. So we want this to be a scalable option, but we need to show and prove that we can do this. So what does it mean to somehow merge blood and EPIC results? So, just to give an example, and I'll wrap on my end shortly, but, patient goes to St. Joseph's Hospital, they're registered, they get a surgery, their nurse sends a referral from the urologist saying, this patient is high risk, they should see an oncologist. But we can take that using EPIC and the data that's entered into JCC. This is where we can use some of our EPIC, Cogito, and other kind of tools to identify this in an automated way, because the patient comes to our clinic, gets some treatment, and is followed for various outcomes. We're trying to say, okay, along this line, these patients get triaged for this test, get us innovative blood tests. This is stored, this is shipped, this is analyzed, and we have results that are uploaded in an automated way. And so integration of EPIC is huge. Obviously, there's a data flow on the EPIC team that needs to be done. It's not without work. Not to bore you here, but you can imagine just even building our LOI and talking to the EPIC team. We looked at every possible interface doctors have in an electronic medical record for the things that we think are necessary, and they need to take this dictionary on the back end and say, okay, what does this look like? So just to show you, these are all the things that we think, and this is trimmed down to say that might matter and where we could find them. So there's many source points from a data analytics and an AI perspective from an electronic health record like EPIC. And again, we need to talk across the city for this. So I think we have a great team. Of course, I'm talking, you're going to hear from Tobias shortly. Daryl Leong, as mentioned, is helping us from the IT perspective. We have a steering committee, including folks that are AI experienced. You see a lot of familiar names. We are citywide, right? McMaster, JCC, ECRI, St. Joseph's Hospital. Everyone here is a player. All the stakeholders are interested. And the Juravinsky family, with their philanthropic donation, is banking on all of us working together here. And we have a lot of names that you'll know. You know Dr. Paré, of course, and some other familiar names here that are really invested as collaborators, kind of senior commissars, so to speak, and those that will help us with the pathology as well. We've broken our team not just by the disease sites that matter, but we have a methodology and design group, we have a precision medicine biomarker group, and we have an AI and data analytics group. And as the overall co-PI, it's my job to kind of make sure we're all meeting within our teams and not to create silos, but just to make sure we have the expertise churning along each of these groups. And then we obviously meet frequently, as Tobias knows, to make sure we are all on pace. And this is where hiring for research coordinators and project managers is very exciting, because this is a 2 to 3 year project. We have milestones, and I won't go through this, but just to show you, there's lots of protocol development phase that we're going to be at in year 1. We're recruiting patients and having our quarterly meetings to the advisory board and adding more biomarker candidates. That's what I'm really excited about, the horizon scan that will evolve as we do this work. And then, of course, showing that we can do this work with patients, have the manual back-end check on the Epic work, but also run it in an automated way. And at the end of this, what is not shown is that we want to be able to have this be sustainable for other tumor groups along the way. So I'll kind of pause there. I've called it open discussion, but I realized I'll be online for questions, and I might turn it over to Dr. Berg or to the team here, however you see fit.
Great introduction of this Q part of the project and the project overview overall. You just have to switch a little bit, and I'll share my presentation. Essentially, more or less starting with what you finished with. Shall we
just continue to share? Continue to share.
Continue to share. Okay. So this is a new project that has just recently been approved. So this will not be a lot of data today that we'll talk about, but really this will be about introducing the project, introducing the players, introducing a bit of the rationale that goes into this, and then trying to also kind of inform the CDCR and people who work on that from a translational side about these opportunities that will arise from this. Okay, so this is the part about AML. So why am I interested in this? It's the most common acute leukemia in the adult population. At the JCC, we treat about 100 patients per year. And unfortunately, the long-term survival for patients with AML is still really poor. It's only about 30%. So if you compare that to the survival curves that you saw on the due cancer, so we still have a bit of a way to go there until we're there. It's also a very heterogeneous disease. And this is one graphic that I'm always showing in this context, because there's not just many different mutations that we're increasingly recognizing as being important, but also different permutations of these mutations in which they can occur. So more or less many of those patients. So there's many, many different subgroups of AML. The most effective treatment that we know of, at least as a consolidative treatment, but also maybe even as a remission-inducing treatment, is the allogeneic stem cell transplant. And here's a little bit how the treatment currently looks like. So when the patient comes in to the JCC and is admitted, what they will often get offered is a treatment that's called an induction chemotherapy. This is an intense chemotherapy. This is old treatment. This has been around for like 40 years or so, since the mid-70s or so. And this, when the patient achieves a complete remission, if it's a higher risk AML, the patient will be offered a transplant. If the disease is lower risk, they would usually receive consolidation, which is additional chemotherapy. If the patient is not in remission, and this is another group that is like a group of big need, then they will receive reinduction. And then if they achieve another remission, then they can get to the transplant, or with novel approaches, maybe straight to the transplant. But even when we do the transplant, and really what I want to highlight about the transplant here is that it's one of the first cellular immunotherapies that we've been able to do, because what we do is essentially we don't just give stem cells, or we don't just transfer stem cells from the donor to the patient, but we also transfer immune cells. A lot of T cells, NK cells, other immune cells. And these immune cells in the recipient can expand and can recognize the AML cells as something that's not supposed to be there and fight against it. Problems that still arise, and you can see this here from essentially the summary of patients who have died after a transplant, what has happened to them. Then the biggest problem is still relapse. The other big problem is GVHD, or graft versus host disease, which is causing a bunch of other problems here as well. So this is essentially an attack of the immune system on the patient. So we may not want to give this treatment to someone who doesn't need it. And we need strategies to favor this graft versus leukemia effect, or the attack of the immune system against over the GVHD. One of the things that can help us there is MRD. And MRD, in the end, is to recognize residual tumor cells. So, and it's an interesting analogy that a colleague from the UK has at some point shown. It's to see that shark somewhere in the depth there. And in order to see into the depth or go into the depth, there are different methods. And depending on which method you use, you can go either deeper, so you can either see with a higher sensitivity or not. Traditionally, when we talk about remission, it's a pathologist looking through a microscope. A trained pathologist is able to see maybe 5 in 100. So if there's the leukemia cell 1 in 20, they will see it. Very trained pathologist, maybe 1 in 100, but that's about it. Because often you have cells that almost look like leukemia cells in the bone marrow, that in particular our early stem cells, they will look very similar to that. So there's more sensitive methods. And this is where essentially the measuring comes in. So often the term is kind of switched now from minimal residual disease to measurable residual disease. So it depends on really how we measure what we can measure. Flow cytometry can go to maybe 1 in 1,000, maybe 1 in 10,000. And then there are PCR-based methods and NGS-based methods that can go down to 1 in 100,000, 1 in a million cells even. And that's really where we need to, or how deep we want to look in order to see if that patient's cured. Some of those methods are there already. This is from a guideline that has been published. So there's the multi-parameter flow cytometry, there's the qPCR, there is NGS here with a bunch of kind of comments here that it's not really there yet. It's still called exploratory here, as well as the digital PCR. If we detect MRD with these tests, it's always the question what to do in this case. Do we know what to do? And it's kind of a funny statement that one of the editors of JAMA at some point made. It's like ordering a diagnostic test, like picking your nose in public. You always have to know what to do when you find something. And so the question is what to do when we find something. And or are we there to know what to do when we find something? And what I want to do with this talk is try to convince you a little bit that for at least for some things, we already know what to do when we find something. This is a case, a patient who I've actually seen in clinic. This is a 67-year-old man who's presented with acute myeloid leukemia, was actually originally treated at a different center, received an induction chemotherapy, unfortunately had disease persistence after the induction, and then received another type of treatment, which is a combination of azacitidine and venetoclax, and achieved a CR. Problem was that at that time, there was still detectable MRD by PCR. So what should we do? And there is essentially 2 questions there. One is, what is the next treatment that the patient needs, and how do we do this? And one treatment or one question is, does that patient need a transplant? There is an interesting study that has been done really here in the UK by the UK AML group. It's essentially a summary of multiple studies where they could show that essentially if the patient's still MRD positive at the time of transplant or at the time after the second cycle, then these patients for sure will benefit from a transplant. So we can already say, even if that patient, like the patient was also refractory to the first-line treatment, so that would already put them into a high-risk group. But even if that patient would have responded, if they were still MRD positive after cycle 2, they would need a transplant. The problem then that comes is that transplant outcomes in MRD positive patients are often fairly poor, which you could see in this UK study where the curves for the MRD patients on the left-hand side were not that great. And we can do the transplant in 2 different ways. When we see a patient 67-year-old, we can either use busulfane in the conditioning, or we can use melphalan in the conditioning, both reduced intensity conditioning regimens. And interestingly, the choice of conditioning can actually matter in terms of how the outcome of that patient will be. And this is a study that was done by the NIH, and that shows that if you use a reduced intensity conditioning regimen that is based off melphalan, the relapse rate and this is much lower and the survival is much better. So this is what probably we should do for this patient, and this is also what we did. So this patient received the melphalan-containing conditioning regimen. So now what next? So what's next after? And this patient, as you remember, had a FLT3 mutation. And interestingly, it's been shown that fortunately for FLT3, we have inhibitors. And it's been shown that interestingly, FLT3 inhibitors and transplant can work together quite nicely. It's a very nice mechanistic study here by Matthew et al., where they could first show in murine model systems that essentially combining this FLT3 inhibitor, sorafenib, with the immune cells, so with donor immune cells, actually prevented the disease from coming back. In these mice, they also showed it in data that they extracted from patients, and they found a mechanism. The interesting thing about the mechanism is that when you have this, or when you treat the leukemia cells with that sorafenib, they start producing IL-15. Is this the whole story? Not 100% clear, but it shows they showed it with a bunch of models actually that this probably plays a role in this context. So this was also then done in a clinical study. This is a randomized trial that was held in, or that was done in Germany. It took a while to recruit, and so there were only 40 patients in each arm, a bit of a combined population, similar to the population of patients that we had in our case. And what that study showed was that relapse-free survival was actually a lot better with being on sorafenib than being on placebo, and even overall survival. So this improves survival. And this is a big difference. This is almost like cutting the risk of dying in half. They also analyzed what the role of MRD in this context is, and now that's getting really into subgroups, so it's a little bit difficult to see here, so it remained a bit of an open question here for this study. But they saw benefit in almost all groups. So the patient that we saw was started on sorafenib and is doing okay. However, he had some side effects from the sorafenib. So, and this is where another FLT3 inhibitor comes in. There is one that's called gilteritinib. This one is a lot more specific for the FLT3. It's effective, it's approved, so it's been used for, this was in a trial that was called the Admiral trial. So this company somehow calls all of their trials according to butterflies. So this was the Admiral trial, and the Admiral trial showed that this is actually, being on gilteritinib is actually better than conventional chemo for these patients who've relapsed. And they also have data that when you put the patients after the treatment, after the transplant back on the gilteritinib, that they had a benefit. So the company went in and designed a huge trial where they wanted to essentially test in a randomized fashion, is this a maintenance that everyone should get? 180 patients each arm, all patients in CR1. This trial was then called MORPHO. The Morpho trial was kind of a disappointment because when you look at the disease-free survival curve and the p-value, it's 0.0518. So the statistician who probably did that calculation for the first time probably kicked his butt, and the whole study team. But there was a problem with this. And there's two problems, essentially. One is the problem, so why did this thing didn't fulfill the promise, kind of. On the other, and it's maybe two reasons. One reason is that there's a bit more toxicity with this compound than maybe originally thought. And the other thing is really, and that's a bit of a problematic thing, and that's, you can kind of tease it apart when you look in different continents, that the patients in North America did as they were supposed to do. So the gilteritinib patients did better than the other ones, than the placebo patients. The patients in Europe and Asia didn't. The issue was that the patients who were put on the trial in Europe and Asia were often further out in the treatment, which you can see here essentially by the number of treatment cycles that they received. And by that, most of the high-risk patients have already kind of fallen off. So they put in a lot of low-risk patients, which you can see in the placebo curves. So the placebo curves in Europe and in Asia are a lot better than the ones in North America. And that's not because they are better in treating the patients with the placebos, but it's really probably because they put in a different group of patients. And you can then, when you look again, and this is where the MRD test comes in. When you look with the MRD test, you can see this, that essentially the patients who have MRD, so the higher risk patients, that they benefited, whereas the other ones did not. So MRD is there. MRD can tell us which patients need the maintenance treatment. And there is another maintenance treatment that I'll probably skip over a little bit because I want to leave us a little bit of discussion room here. This is DLI, so this is giving donor immune cells after the transplant, which can also decrease the relapse rate, which are all things that we can do essentially in terms of improving this. This is also interesting in the sense of that we also have some projects in the lab interested in this question. And actually, it's kind of funny that you who came in today, who started this project started this project almost 5 years ago, which is essentially, and this is from a review that he wrote, a project on essentially trying to reverse immune escape mechanisms. As you know, some of those escape mechanisms is by the downregulation of HLA molecules. These HLA molecules here, in particular the class 2 molecules, are often down in patients that relapse after transplant. And our lab is very interested in LSD1, which is histone demethylase. So it's an epigenetic player, so it can reactivate genes that are downregulated. And so what Hugo did then in the project was, look, can we actually re-upregulate, or can we increase, re-increase that low expressed or that lost HLA-DR molecule? And he could show here in one cell line that actually you can do this. And then by doing a co-culture experiment here with leukemia cells that express ovalbumin, he could also show that these leukemia cells that are then co-treated also have or do a better job at activating T cells. So this is something where also clinical studies or innovative research could come in. So MRD testing can help us decide who needs a transplant, can help us decide how to do the transplant, and decide what to do after the transplant. So this I want to skip over. So we want to introduce and expand MRD testing for patients with AML. We also want to improve biobanking procedures so that we have material to do this type of research. And this is what the AML part in the Elevate PM project is. So when we look at the moment which MRD tests we have, so these are essentially for patients with NPM1 mutations, that's about 30% of patients. We have some limited availability for that. We have some availability for the CBF leukemias. We don't have anything for the other patients. So in the end, we want to introduce MRD testing. And when we think about this, what to do or what to best introduce, And this is probably also, or that we can base essentially on these trials that have been ongoing and that I showed some of the data to you, is that we should probably do this using next generation sequencing, because this will give us essentially a test that's applicable to all patients or most of the patients. So we want to, in the context of this project, establish NGS-based MRD testing. This will be done in collaboration with the genetics lab at the JCC. And then we want to create a combined workflow for biobanking and MRD testing in collaboration with the citywide biobank, and really do this in a clinical study with patients with AML. We want to include 20 patients, do this before and after transplant, and use this test also then in the context of like guiding treatment. There is an NGS-based test. This is this Oncomine myeloid MRD test that I'm currently favoring for doing this. This is not a final thing yet. This is something that we're still working with the genetics lab in establishing. And we want, and this is a bit similar to what Aly-Khan showed you for the GU cancers, we want to establish a workflow where really a patient who comes in can receive personalized care, either standard of care, personalized care, or within clinical trials. And this should be facilitated by data that we have in the system, that we get either through this testing pipeline that we want to establish, or the annotation that we get from the EPIC system. So this is what we want to establish within the Elevate PM project. And with that, I would like to conclude. Thanks the Juravinski Research Institute, obviously, for taking that on that endeavor with us to fund this. And obviously, again, saying that we are open for collaboration with this. This is a new thing. And so hopefully we can get into great and new collaborations with this project. And with that, I would like to conclude.